Hello, I'm Charlotte Augst. I'm a consultant. I work with a range of organizations, mostly in the not-for-profit sector, advising on strategy and community engagement largely. And I've got a very strong professional and personal interest in end of life. And I am therefore really glad that I work with Compassion in Dying on this and a couple of other questions that are central to their work. You will have picked up, if you're in the circles that I'm moving in, that there's a lot of discussion about trying to improve end-of-life care. We're all waiting for the 10-year plan for the NHS, and there have been some really substantial discussions about including some end-of-life transformation program / funding in that plan, which we're all holding our breath for. There's commissions, as you're aware. There's a lot of conversations in Parliament, not least because of the terminally ill adults end-of-life bill. There's very strong evidence that most people, many people, want a gentler, less intervention-heavy end to their lives. But there's also very strong evidence that many people don't get that, and that they end up being blue lighted or admitted to hospital in the last days or hours of their lives, and that things unfold in ways that they might not have wanted. And we think this is not because anybody's out to get anybody, but because services don't seem to be aligned in a way that correspond to people's preferences. So we believe we need better conversations, and we need the priorities people set out for themselves to prevail in moments of high emotions. And for that to happen, we need a cultural shift, both in families and communities, to help have these conversations, but also in services and with healthcare professionals. And we submitted evidence from Compassion to the Lord Darcy review about productivity in the NHS, and we're very pleased that he picked up on our submissions and agreeing that culture change was what was required, rather than just working within a services framework. And other people have obviously recently also put on the record that they believe we need a different kind of conversation. And for that to happen, people need better information and better support. The Ombudsman has said this recently, and CQC. So we are talking today about such a public information campaign because we want to see some action on this idea of culture change. This is something that policy circles struggle with. And those of you who work in health policy more widely will appreciate that this is very prevalent in end of life, but it goes way beyond that. It goes into long-term conditions management or prevention or wider behavior change agendas, where we struggle with moving beyond saying we want people to be in control and actually spelling out what would be required to give people more control. So this is the focus of today's conversation. How do we make culture change real? And a good public health campaign is about more than just giving people a leaflet or telling them that there is a form to be filled in. So we're going to learn from existing practice and from some really thoughtful panelists who've all generously agreed to speak to us today. Before I start introducing those panelists, I will very briefly set out a bit of housekeeping. So I will ask panelists to come in with a very brief presentation. And because there is so many of you today, we want to hear your thoughts and your questions, but we had to ask you to do this through the Q&A function rather than through the chat. You might have been on other webinars where you can chat with each other, but we felt that was quite difficult to moderate with the numbers of people we have online today. So you please, when you have a question or a thought, pop it into the Q&A function. If you're looking at a laptop like me, it should be at the bottom of your screen. If you're on a phone, it might be somewhere slightly different. But if you have any problems figuring it out, we have some lovely people at Compassion in Dying who are here to help. Their email address is info@compassionindying.org.uk. So if you're struggling with getting involved, please reach out to lovely Zach, who's doing that. We then have lovely Gemma raising questions with us as a panel, and we will try to get through as many of those as we can. And we will also obviously go through all of this after the webinar and make sure that we make everybody aware of what has been said. We will record this webinar and we will share this back with you if you want to share it on with colleagues or the like. Before we kick off in earnest, I just want to say conversations about the end of our lives are kind of very humanizing, but they're also very challenging. So if you find yourself feeling a bit wobbly at times, be gentle with yourselves, and we will all try to be gentle with each other and assume everybody has good intent in all of this. And even if we disagree at times, this doesn't minimize that we all want to get it right for ourselves and for our loved ones. So on this note, I will now introduce our first speaker, Amanda, who's joining us on her break. She is a nurse and she's here today to speak about her mum's end-of-life experience. And what she has experienced has taught her that we need a better conversation with the public and professionals about how end-of-life can unfold. Amanda, I'm handing over to you now, and I'm going to mute myself.
Thank you. So my name's Mandy, and today I'd like to talk to you about my mum's experience and how even as a nurse, I missed the opportunity to help my mum record her wishes and treatment at the end of her life. I'm here as I would like to share my mum's experience with you in the hope to change things for other people. I'm working as a nursing sister in a haematology unit in a teaching hospital in Manchester. My mum, Anne, had a few health complaints, but her main health problems included poorly controlled type 2 diabetes, high blood pressure, COPD, end-stage 5 renal failure, and an EGFR of 8. It was discussed that my mum was not fit for kidney transplant a few years prior to her death in October 22. Mum had spoken about home dialysis, however, this had never been started. On reflection, this would have been the best opportunity to discuss her priorities and wishes for the future and likely scenarios such as do not attempt CPR. Mum was a very strong character who knew her own mind, and for decades she would say things like, when your time's up, and when it's my turn, I just want to drop dead. Over time, we could see that our mum was slowing down, even though she would never give up. She hated staying in the house, and mum pushed herself to live every day, even if she was having a bad day. One morning, on the morning of the 8th of October 2022, my mum and my niece Claire and myself, we went out shopping together. Mum was her usual self, buying shopping, picking up Christmas presents for the family. She was very happy that morning. A few hours later, we got into the car and drove to a nearby cafe to have our lunch. We was all chatting and laughing in the car as normal. We got out of the car and began walking down to the cafe. Halfway down, I noticed Mum was struggling to breathe. We stopped for her to catch her breath, then carried on. We got to the cafe door and Mum was really struggling. We took a minute's rest before we went into the cafe. We got Mum sat down and she managed to take her own inhalers, but her breathing was just getting worse. Claire rang for an ambulance. There was nothing we could do. I held my mum in my arms. Claire and I are both healthcare professionals, and we knew our mum was going into respiratory arrest. And within 5 minutes of us entering the cafe, my mum died in my arms. I started CPR immediately, and it was only at that moment that I thought Mum was never going to survive CPR due to her comorbidities. Claire remained on the phone to the ambulance. A lady from the cafe ran to obtain a community defib machine. 2 police cars arrived to help. 1 officer took over compressions while I continued with mouth to mouth. The defib was applied, but no shot was advised. We continued with CPR. 2 ambulances arrived and took over. I stood back and watched in despair as they worked on my mum. They used the Lucas machine to assist with compressions. They did everything possible to save my mum. We attended the local hospital where a full team of A&E staff was waiting for us, who worked hard to try and save her. Mum was pronounced dead in A&E. Mum had to have a post-mortem and referred to the coroner. All this trauma delayed us being able to lay Mum to rest. It felt like an eternity. Not to mention the cost to the NHS with all the services and the equipment we used. Mum was very proud and private person, and she knew 100% Mum would not have wanted to be in a cafe, blouse ripped open, on the floor, full of blood. Mum had the perfect death in her eyes. Her time was up. She passed very quickly, and it would have been much more dignified for Mum to stay in my arms and for me to produce a do not attempt CPR form to an ambulance crew. More than anything, I know that that's what my mum would have chosen, given the opportunity to consider CPR long before a crisis. Myself, my sister and my niece, we all work in healthcare. However, none of us thought to have the DNR, do not attempt CPR conversations with our mum. If we as healthcare professionals didn't think about it, what chance do the public have? So from that, what would we like to see change? We need to get the message out there so everyone can have the opportunity to think through their wishes before a crisis. It's not just old people that die. Most importantly, it needs to be spoken in layman's terms so everyone can understand what's being said. We need to be open and transparent with end-of-life conversations to enable more informed consent around treatment decisions. CPR is a wonderful thing for saving lives, but it's not appropriate for everybody. And we must have a deeper understanding of the reality of CPR and the importance of do not attempt CPR conversations, and help people understand other treatment decisions they may face down the line. We must give people ownership regarding their own choices and care of death. I would love to see a campaign where we can share real life stories like my mum's, so we can support other people in opportunities of conversations and their own wishes and preferences. Death is guaranteed for every one of us, and we need to change the culture in the way we view death. We get many chances at life. We live every day, but we only die once. We need to get it right.
Thank you so much, Amanda.
Thank you.
Am I unmuted? Yeah. Thank you so much, Amanda. That is a very generous thing of you to share with us all. Usha, that's quite a hard act to follow, but I'm handing over to you now. Usha is the Director of Partnerships and Services at Compassion in Dying, and she will share findings from research they have undertaken into people's experiences of making and recording decisions about end-of-life care.
Thanks, Charlotte, and thank you, Amanda, for sharing that. I'm going to start with some stats from our research at Compassion in Dying as a context setter to what I'm going to say. So 8 in 10 of us say we would prioritise quality of life over quantity towards the end. But when you speak to bereaved people, 1/4 of them say that the person they looked after received medical treatments that they would not have wanted in the last year of their life. So that suggests there's a huge gulf between what people want to prioritise when asked and what happens to them in reality as they reach the end of their life. At Compassion in Dying, many people tell us of feeling like they have to fight a medical system that can default to extending life without considering what's specifically right for each person. So people's desire for a less hospital-based, less intervention heavy end for their lives is clear, but services can struggle to respond to these wishes. So I think it's clear that there is an issue here that needs attention, and there are, as Charlotte's hinted at already, a great many conversations happening at the moment about improving end-of-life care. But the solutions being discussed tend to focus on how we can deliver better, more integrated services in the community and ensure better access to palliative care. And these things absolutely are needed, but I think I would like everyone here today to consider that improving dying is as much about helping people and their communities to make their own decisions as it is about improving the mechanisms of service delivery. And the response to the number of people who experience admissions or interventions that they don't want at the end of their life cannot only be investment in more or better services. So what's needed? I think we need investment in cultural change. So how we all in society understand and talk about our end-of-life treatment and care. We need people to have clear and accessible information to help them consider their priorities and understand the treatment decisions that they might be faced with as they approach the end of their lives. They need to know how they can record their decisions, and it's often absolutely crucial to do that if you want your wishes to be respected. And end-of-life conversations should be a normal part of life if people can have them, and there should be many opportunities to revisit and record these discussions if people want to. And more people actually have thought about this than you might realise. So in 2021, we did some research with 1,000 people over the age of 30 with a nationally representative profile, and we asked them how they felt about considering their end-of-life wishes. Interestingly, 6 in every 10 people said it's something that they had thought about before, that it's something that they would consider in the future, but they hadn't looked into the details of. And maybe unsurprisingly, I don't know, only 1 in 20 people had either started researching, writing, or had completed the process of recording their wishes. So how do you move people from thinking about it to doing something, effectively to changing behaviour? Well, a good campaign, and Charlotte has said this already, is not just about giving information. So everyone is going to come to this with different experiences, different starting points, and we need to understand these. There isn't one single version of a campaign that can create change across all communities and parts of society. So what I want to see is a long-term programme that evolves over time and adapts to audiences and responds to the experiences of many different places in society. And I think that the answer to how to do this lies in evidence-based, sensitive, rigorous research. And that's research that's specific to audience and community, which seeks to understand what gets in the way of conversations and action, people's experiences, what people find meaningful, what people find motivating. And as a gentle provocation, I don't think that anybody who's already an expert in end-of-life care should design a campaign like this. So fundamentally, the best people to tell us how to do this are people themselves. And that's why we need research before we get anywhere near the how, because the how needs to be led by the who. And any attempt to drive this change that's not led by lived experience is likely to fail. Thank you.
Thank you, Usha. That was wonderfully clear, and I like the gentle provocation at the end. Maybe we thoughtful, intelligent, very knowledgeable people are not actually the right people to answer the question, what do people need to respond to this vague feeling they have that this is a thing they might at one point want to have a conversation about? We're moving swiftly on to the third speaker, who's Rekha Vijayshankar. We were meant to have Miranda with us today, but Miranda had to drop out due to health reasons. But we have Rekha here, who's a wonderful replacement. She could not join us this lunchtime. She's also working as in an NHS hospital, but she recorded a short message for us, which we're going to play in a minute. Rekha is a Churchill Fellow, a Queen's nurse, and a palliative care researcher. And most excitingly and most innovatively, she also founded something called the Neighbourhood networks. And that was her attempt to get into different kinds of conversations with racially minoritized people in 2 parts of London. And she's going to reflect on what it will need to give people agency and choice who might start from a different starting point, very much emphasizing that one size is very unlikely to fit all. Gemma, do you want to see whether you can get Rekha's video to play?
Good morning, all. My name is Rekha Vijayshankar, and I'm a public health and a palliative care nurse and researcher, and I work with resource-poor, racially minoritized communities. Today, I share with you some lessons I have learned from my work so far, which may be helpful in framing the thinking about care planning and death autonomy in racially minoritized communities. The first lesson I've learned is that of systemic irrelevance. These communities tell me that they feel systemically irrelevant in the context of a health and social care provision that is bureaucratic, opaque, normative, top-down, overstretched, talks in jargon, is increasingly online when they do not have the language or the IT skills for access. They tell me that information leaflets are helpful, but they are in a language that these communities may not be normally proficient in, leaving them with more questions sometimes than answers. The second is the issue of intracultural stigma. They spoke about their pervasive stigma against serious illnesses like cancer, dementia, etc., which often prompts late disclosure when cure is harder. They spoke of their poor knowledge of their illness, of its symptoms and prognosis, their fear of medication like morphine, their desperation reflected in accessing occult healing practices local to their communities and their culture. They spoke of their lack of knowledge of end-of-life systems in our healthcare outside the remit of a hospital. They spoke about the expectation of a gendered caregiving, social isolation when caring for someone for close family with a serious illness. I have a quote here that may be of interest. Families sometimes try to make noises, but they don't want to get infected with this cancer. And where do they have the money anyway to help me or my wife? Said a 32-year-old Nigerian man dying of chronic kidney failure and prostate cancer. It is in this context of powerlessness and confusion that we have to ask ourselves, 1. How relevant is our conviction of death autonomy for populations that are essentially collectivist in their decision-making character? Is our passion for care planning an Anglophone vision? And how relevant is our conviction of the benefits of care planning for populations who do not understand, do not trust, or even feel empowered in a systemically racist and structurally unequal and bureaucratic health and social care framework? Centrally informed by their cultural and religious frameworks, in a socio-economic context they do not think they belong to or feel that they matter in, with colonial histories of injustice and violent deaths, what incentive do these communities have to engage in care planning discussions with an external healthcare professional? These conversations are being had, but are being had inconsistently and within the walls of a family unit. I run a project called Neighbourhood Networks with racially minoritized population that aims to build social infrastructure in care planning, serious illness and loss so that they are able to then provide peer support to each other during difficult times that is local and culturally aligned. Its success, measured by evidence-based tool, is partly attributable to its acknowledgement that care planning is a behavior, and a change in this behavior is not needed just within the racially minoritized psyche, but also within that of us who, with our Eurocentric gaze in how we think, act, research, and relate to others, quote unquote, whose lives and thoughts and being are informed by a diverse richness, we can inquire about if we bring the humility and the patience to know better and to grow from. Thank you.
God, I mean, we are really bringing out the big guns today, aren't we? This is such high quality content. I hope you're keeping up. It's going to get better and better. We're now hearing from Sue. Sue Baker is director of an organization called Changing Minds Globally and is a founding director of a campaign you might have heard of called Time to Change. She has worked to destigmatize mental health for almost 30 years in the UK and globally. In England, she helped set up the Time to Change campaign. And we think there's a lot there that we could learn from that practice and that experience she brings. And she's generous enough to share this with us today. Over to you, Sue.
Thank you, Charlotte, and good day, everyone. Thank you very much for the privilege of being able to hopefully share some parallels and learning with you today. So what I'm going to talk about is driving experience in the mental health field of driving behaviour change and shifting social norms at individual, local and national levels. So most of my career, which is possibly 30 years now, has focused on making a very taboo topic, mental health, okay to talk about, giving them motivation and tools for talking, but more importantly, then changing behaviour. Public behaviour, key target audiences, including employers, the media, health and social care professionals. So we improve knowledge, attitudes and behaviour in order to improve outcomes for those of us directly affected by mental health problems, which is roughly 1 in 4 of us. In this case, what we're talking about today is a campaign to improve end-of-life outcomes or experiences. And I think, as we've said, I think there are hopefully many parallels which might be useful to share. So first, I'm just going to take us back to the mid-2000s when mental health was definitely in the too hard to do basket, both for the public, for employers, for the media, and it was still a political football bounced around by political parties, and to be honest, by NGOs and other key stakeholders as well. However, mental health stigma and discrimination were very commonplace. From various different academic surveys and studies, we knew that 91% of people with mental health problems, more severe mental health problems, using secondary mental health services reported discrimination in an average of at least 5 areas of life. Most commonly from the very people you seek support from and expect understanding. So coming from family and friends, at work, from your community, as well as people working in mental health and social care services. Almost 2/3 of people with mental health problems in one of our surveys at Time to Change said that the stigma was as bad, if not worse, than the mental health problem itself. And that was also replicated in a Lancet Commission survey, which I can share with you through a global survey of people with lived experience of stigma. And in England, changing attitudes to mental health had never worked. Attitudes have been studied since 1993 using the same validated tool of public attitudes. But we had already learned from very successful evidence programs in New Zealand and then in Scotland. And we built a significant new evidence-based approach here in England, which has been adapted to very different contexts across global regions. Mind and Rethink, 2 mental health NGOs, got together to set up this national programme to address mental health stigma and discrimination, and we researched and tested a brand, and it became called Time to Change. We ran it from 2007 to 2021, first securing funding from the Big Lottery Fund from their very big national wellbeing portfolio, and Comic Relief gave us their biggest ever grant every year for nearly 15 years. And after 4 years, we replaced the lottery funding with funding from the Department of Health and Social Care. Our outcomes on attitude change and discrimination were replicated in the government's, at the time, mental health strategy. So we were entwined and embedded in relation to policy. We had an average of £4 to £5 million a year with very defined outcomes through academically evidence with ambitious targets every 4 years. We became one of the most evaluated mental health campaigns in the world and invested 2 million of the 20 million every 4 years into very robust academic evaluation with the Institute of Psychiatry, Psychology and Neuroscience, bit of a mouthful, at King's College London. I'll just call it that from now on. Hence, we were referenced in that Lancet Commission report published in 2022 as one of the most evidence programmes in the world. And just to say, so what did we achieve? Well, our final impact data said 12.7% of improvement in attitudes had been delivered. That had never been achieved in our culture and context across multiple cultures as a society before. And this was described in one of the academic papers as a sea change. There was a 15% reduction in average levels of discrimination. You remember we talked about the 91% in at least 5 areas. And that was reported improved behaviour, reported by people, again, using secondary mental health services. It was a very academic study. We had significant improvements in media coverage of mental health, which was often a driver of those misinformed negative attitudes. And we also were awarded an award from the Royal Society of Public Health as one of the top 20 public health achievements in the 21st century, which was a great honour to be awarded that. And the public who were aware of the Time to Change campaign, so they could recall some of it, were more comfortable disclosing their mental health problems to their families and friends at work, and very importantly, more willing and able to seek help from their GP. So we knew it increased disclosure and discussion as well. But this all took a social movement. I wish we had time to talk about it, but we worked with 3,000 employers from all sectors, 2,000 schools, all the Premier League clubs. If you're shifting cultural social norms, you will reach audiences where they are at by working as a social movement with uniformed messaging that obviously is adapted to very different communities and different cultural contexts, like Rekha was saying. The media ran their own mental health season. We worked with the royal family and William, Harry and Kate, as they were at the time, to set up their own mental health anti-stigma campaign. So what are some of the key learnings? And I'm going to very quickly mention that, if that's okay, that I think could translate well to a campaign or programme, should I say, but in this field. Any campaign, as I think Charlotte's already said, should not be a one-off endeavour, but take a long-term approach. You'll need to take your target audiences, multiple audiences, on a journey over time to secure changes in knowledge, awareness as an issue, and we need to change attitudes, overcoming fears, challenging myths, misconceptions, harmful beliefs, and behaviour change, whatever the call to action is. And when I say campaign, it's a programme. It's a behaviour change model you'd be looking at. Yes, it provides information and tools and services, helpline, peer support group forms, etc. But we had 7 national projects, only one of which was the headline social marketing campaign. And as I think Charlotte and Usha said, audiences will be at different starting points, some nearer to change than others. And there will be, many complex barriers, whether they're cultural, faith-related, practice and policy in workplaces, for example, or services. After only 9 years of our campaign, did we decide to prioritise the cold men that we call cold because they were the furthest away from this topic. Mental health wasn't relevant to them, their families, their mates, their colleagues. So it was an audience that wouldn't have engaged with our campaign. And after 9 years, we then spent the next 6 years working directly with them as a target audience, as well as with African and Caribbean adults. We did a pilot with South Asian communities. We worked with children and young people. And very importantly, we'd had some very successful pilots with professional audience who were harder to shift because of their own policies and social norms as professionals. So we worked with GPs and GP practice-based staff and mental health professionals with good behaviour change results. And then finally, I could go on, but I'll finish with this one, just to reflect what you said, Usha, which is that from the outset, we said that Time to Change should not be designed by any of us too close to this issue. For all the right reasons, we already know too much, but by qualitative research with potential audiences and constantly reviewing that data to find out where your audience have gone, and only then choosing the target audiences you're going to work with and testing creative with them, but have clear outcomes that you will be accountable for and keep focused on those outcomes. and work as a movement, I would say. Many people have a role to play in this. This isn't a, single issue for one organisation. It's for a movement, but do have a lead that will drive this and get more people on board. And finally, lived experience, just like you, Amanda, were saying, has to be at the centre and forefront of your work or campaign, hearing from people, but also all the way through any future programme. We used to talk about lived experience being like the writing in a seaside stick of rock. It needs to go all the way through everything you're doing. And I hope that's helpful. Sorry for going a bit over time.
Thank you, Sue. That's been so interesting and inspiring. It's kind of easy to throw your hands up and go, oh, culture change is actually really difficult, and then park something like this in the too difficult box. So it's great to hear that, yes, it's not straightforward, but it is within reach. Allan, you're next. Professor Allan Kellehear is a professor of end-of-life care at Northumberland University, and I didn't know this, but I think it's really, really exciting. The founder of an international public health movement in palliative care. And since we're talking about public health today, we thought Allan is a perfect speaker. He has a long-standing research and publication focus on the history, social psychology, and anthropology of human dying. Over to you, Allan.
Okay, thank you, Charlotte. So my experience actually reflects Sue's previous talk. I've been heavily involved in bringing the public health movement to palliative care. So when I first came into palliative care, coincidentally, about 30 years ago as well, it was a clinical endeavour and a very much in-house kind of doctor-nurses game. Of course, the problem with this is that dying people and people who live with bereavement really only spend less than 5% of their time in front of a doctor or a nurse. So 95% of the time, dying people are alone, or with their families, or with their friends, or their neighbours, or their workmates, or the school playground, or with the stereo system, or the internet, or with their dog and their cats. So really, the action in end-of-life care, if you're really serious about this, is in the 95%. And that's where the public health movement has, that's where the public health movement likes to address those kinds of things. We like to be where people living with a life-limiting illness are, and where caregivers are, and where people living with loss and grief are, and that's everywhere. So we follow them into their workplaces, and we follow them into their neighbourhoods, and we follow them into their football clubs and their golf clubs and the bowling greens and the music studios and the museums and the faith groups. So that's the public health movement. And I think I've spent a very long time, most of my career, in developing this public health approach to palliative care, very much like Sue, in fact. But I think one of the major reflections I take in the last few years in particular is to step back, and this is what I'm asking you to do as well, is to think about the fact that we're all building an end-of-life care system. We're building an end-of-life care system, not a palliative care system, an end-of-life care system. And if you think about this at the other end of life, for example, if we think about the bringing into life system, the birth system, if you like, before 1960, basically people's idea of contraception was the rhythm method, maybe withdrawal. And then if that failed, of course, you could always have a child into the family, or you could go for an illegal abortion, or you could adopt. You could adopt the child out. And that was basically it after the Second World War. Now, since then, of course, we've built an entire bringing to life system. So now there is, of course, not just the rhythm method, but we use condoms. People know this. We use contraceptive pill. And when those things don't work, we use the morning after pill. And when those things don't work, of course, we can use abortion, elective abortion, as well as medical abortion. If you can't have children, of course, we have fertility technologies and interventions now. We have IVF and we have surrogacy. These are all options that people have. And then, of course, if you go through and have the child, there's not only adoption, local and international, there's fostering as well. We have an entire health and social care system devoted to supporting diversity at the beginning of life. It's not one size fits all. That whole thing is gone. And I think what you have to understand is that in the last 10 years in particular, we've been building an end-of-life care system. So the hospice and palliative care system is the most dominant, the one that gets the most publicity, of course. But we also have doulas, and we end-of-life doulas. We have primary care physicians. We have community nursing involved in end-of-life care. We have retirement and nursing home programs, and there's a lot of work done around retirement and nursing home programs. We have the assisted dying movement, of course, very similar to the issues around abortion, if you recall. Those of you who are involved before the mid-1960s, abortion was illegal, and people agonized over this. It's not for everybody, and it's still not for everybody, but it's legal. And the assisted dying movement will reflect that. It will inevitably become legal around the world. It's not for everybody, but it will be one part of the end-of-life care system, the public health end-of-life care system that we have. We have the compassionate communities movement, which is part of the public health palliative care movement. We have the village movement, the movement around people who are older people who are collectivizing and living together and supporting each other's needs. And we have, of course, dementia-friendly communities, dementia-friendly programs, and we have people who like to die alone. And that's on the increase. People who don't want any services at all, don't want to be compassionate communities, don't want dementia-friendly communities, don't want community nursing. They just want to be left alone in their homes to die independently. And increasingly, we're seeing a number of people around the world. I think 1% of all deaths are people who are dying alone, and it is the most rapidly growing form of dying. And it's a preference. It's a form of dissent. It's not necessarily an outcome of loneliness or failure of public services. So we're building this large-scale end-of-life care system, and we're all involved in this. And this is really important to reflect the diversity of our society, the cultural diversity, the social diversity, and also the social inequalities which are endemic in our society. And therefore, it's really important at this stage of our development that we think very seriously about the public health information and education needs of our population. And that's why in public health palliative care, we are really keen to do two things. We're interested in grassroots movements, we're interested in community movements, but we are also interested in top-down movements. We are interested in additional resources, additional services. That's why that in principle, assisted dying and the doulas are very important to promote. These are services that, that the state provides and communities can supply as well. We're interested in things like the equivalent of family planning clinics.
Allan, can I ask you to wrap up? Sorry to interrupt.
We're interested in promoting those kinds of information resources, something like citizens' advice bureaus and so forth. But we're also interested in workplaces and schools, providing engine rooms for people to have those discussions and to enhance those practices. Thank you.
Thank you so much. And another speaker who doesn't shy away from the difficult subjects. Thank you. Finally, we've got Tom. Tom Wood is a nurse and clinical lead for the Resuscitation Council, who work in partnership with Compassionate Dying on a number of issues. Tom will be talking about what the Resuscitation Council has learned through developing and delivering the respect process. And I've seen some of you in the Q&A talk about the respect process and questions you have about how that can be made to stick. And I think you might be focusing on how clinicians can be better supported to respond to people's wishes. Over to you, Tom.
Thank you, everyone, and thank you for the opportunity to be part of this panel. As mentioned, I'm a nurse by background, and I currently work as a clinical lead for the Resuscitation Council. In my nearly 20 years as a nurse, I've been part of many experiences that involved resuscitation and also providing and being part of care as people near or at the end of life. A topic that is very pertinent to resuscitation and often comes up in discussions around care at the end of life is the appropriateness of CPR and other such interventions during this time in someone's life. Now, in my time of working in intensive care, emergency departments, medical wards, and also in hospices as well, I've been privy to conversations related to this and exploring people's thoughts and feelings about what treatments they may wish to have towards the end of life, or maybe, and also trying to reframe what may or may not be appropriate in helping them achieve their care goals. I've been involved in experiences when CPR has been deployed inappropriately, when it's not been discussed with that person and their loved ones to see whether it would be in their best interest and in line with what they wish to prioritise in their care. And I've also been part of times when these conversations have been had and treatments have been tailored to help achieve someone what they wish to prioritise in their care, whether that be living as long as possible or whether it be prioritising comfort and quality of life. From a personal and professional standpoint, I can say that being part of these conversations is an extreme privilege, and especially when it then comes to pass that you are involved in the care of that person and those near to them as they reach the end of life and beyond. I can also say that on a personal level, being part of this, I know how important it is to have these conversations, because when they're not had, it means that care and treatments can be delivered that are not in line with what someone wants to achieve or how they wish to leave this world. At its most raw, it can be that someone where CPR is not an appropriate treatment because it will not help reverse the dying process, and someone is naturally in the dying process, it can deprive them of a peaceful death, where other treatments that can help manage their symptoms and it is not provided, and it can be a distressing experience for all people involved. The Resuscitation Council, our core mission in a sentence, is to ensure that everyone who has a cardiac arrest has access to appropriate CPR. And appropriate is the key word there, and that's one that often needs much more focus and much more discussion, particularly in the context of how we are talking today, and particularly if it were to be factored into a public conversation about end-of-life care. Resuscitation Council's long supported conversations and awareness amongst members of the public and clinicians alike of when certain treatments for resuscitation may or may not be appropriate. Historically, that was by sharing information about DNA CPR processes and other similar kind of clinically focused processes. Since 2016, Resuscitation Council supported the development of the RESPECT process, and now my key role there is to support the ongoing use of that process across the UK. RESPECT can be used by all people who wish to record care and treatment recommendations for their future care, but it's particularly relevant and is used a lot in end-of-life care where this process is used. It can help facilitate these often difficult but really important and often rewarding conversations between a healthcare provider, the person they're caring for, and those close to them, to help explore what the shared understanding of someone's illness is, what they most want to prioritise in their future care, so that the clinician can then provide realistic and personalised treatments to help them achieve this. Also, when necessary, where there may be a misconception that CPR will reverse a naturally occurring dying process, to help explore that and where necessarily challenge some of those misconceptions that are commonly held. I was struck from listening to Usha about an ongoing challenge here, and in my role overseeing and listening to experiences of RESPECT being used in emergency care and treatment, I get a huge privilege to listen to other people's experience as well as relate it to how I've used it in the past. And I think the challenge for all involved here is that there's a challenge for the public to be empowered to talk more about emergency care and treatment, about dying, about what may or may not be appropriate or what they may or may not value towards the end of their life. There's also importantly the challenge for clinicians to listen more, to ask questions, and not be afraid to relinquish a little control, to allow someone to express what is valuable to them and how they may wish to exit this world. As Allan said, there's lots of thought and consideration before a child is born as to how that process may look, and it can't always go to plan, but the opportunity is provided to help those present during that delivery of how that they can best facilitate what's in line with the what's envisioned by the parents. The challenge
Sorry to
is
cut you short again, but we want to have a bit of time for questions, if that's all right.
absolutely, yes, yeah.
You
Processes and conversations need to be had to allow those conversations to be had and allow that chance to be explored. Otherwise, we deprive people of what could be the only chance they have. Well, the only chance they have to as they leave this world. Thank you.
Thank you, Tom. So much to say, and bad chairing on my part that it's now 10 to, and we haven't got that much time. I'm going to try to get through 3 questions. Looking at the Q&A, and many of you have put your questions there, I find there is an overwhelming theme that there's a lot of worry here that people have tried to express what they want, but they don't trust that this will be adhered to and that their wishes will prevail. So I think there's a question here about what do we need to do to ensure that health and care professionals are ready for this conversation? And I'm very quickly going to ask Tom to answer that question. Sorry, I should have said Tom first. This one's coming to you. I'll do better with my next question.
My brain was just recovering from
Sorry,
talking. But
2 minutes, Tom, 2 minutes.
I think it is important that healthcare providers and clinicians are given the tools to be and the confidence to be able to facilitate these conversations. Something I know again from my personal and professional insight into care at the end of life is that people very often want to talk about this, and but healthcare clinicians, particularly those who may not be quite as experienced as others, are often worried about bringing up the subject, about particularly if they've experienced a cardiac arrest, for fear of upsetting that person. I know again from different insights that it's not going to be news for someone, particularly if they have a terminal prognosis, that they are going to die, and they are often waiting for the opportunity to discuss that. So I think it's important that healthcare professionals are given tools to help support that conversation and the confidence to explore it. So to ask questions and be willing to listen, because I know from people, myself and others who have used the respect process or had opportunities using other tools to ask questions and listen, that they'll very often be surprised at how much insight a person has and how much that they are just waiting for the opportunity to share that. And then that healthcare professional can then translate it into realistic recommendations for when an emergency or the end of life time comes near.
Thanks, Tom. And I should say, if any of you watching this and listening to this do have concerns about your own wishes and how you can make them stick, please do reach out to info@compassionanddying.org.uk. This is clearly, that is the job of Compassion and Dying, and they're here to help you make sure that your priorities are recorded in a way that the health and care system is obliged to listen to. I have a question for Usha now. The Parliamentary and Health Service Ombudsman has asked the other side of the question. They're on the call. And the other side of the question is, what support do people and communities need to make this work? And in particular, I was wondering whether you could take into your answer the challenge that Rekha posed very eloquently, that this can't just be white middle class people saying, oh, just fill in this form and, you know, this is how we think about our own death and dying. And is there something about end of life planning that is actually Anglo-centric or middle class centric in a way that excludes people? Usha, what comes to your mind?
Thanks, Charlotte. It's a great question. I really heard Rekha's challenge about, are we trying to do something that's very Anglo-centric and get people to complete kind of Anglophone forms, essentially. And I think for me, it's about understanding, and I mentioned this earlier in my talk, the different starting points at which people are coming to this from. So people who have high levels of health literacy and a concept of agency and autonomy already will be coming to this from a very different place to a racially minoritized community who might feel that they already don't have much of a say in things that happen to them. And we need to understand and respond to this, to know what information works, and that might work for one person but not work for another. But I think in response directly to the point about it being sort of Anglo-centric is that you can't get away from the fact that in this country you essentially receive health and care within a Western system, and so you can't assume that healthcare system is going to be able to know the individual wishes of each person. As Allan said, one size doesn't fit all. So we're not when we're thinking about a campaign like this, we're not talking about trying to corral people into a specific set of decisions. We're talking about how you ensure that anyone who wants to can understand their options and make informed decisions based on what quality of life means to them. And I know we're short of time, but the one thing I sort of wanted to end on is the fact that I think what's fundamental to this is the fact that if you ask somebody, do you want to have a chat about your death? Their usual reaction is no, thanks, not really. But if you ask people, do you want to have a say in medical treatment decisions that are made about you? Then pretty much everybody says, yes, I do. And that's what this is getting to the heart of. It's that things will happen to you potentially. And if you want to have a say in what those decisions are, then there's things you can do now to make sure that your wishes are central to that.
Thank you, Usha. Nice and clear. I think we are occupying that middle space between a community conversation and a service conversation, and we try to bridge. That's the purpose of the campaign. I'm going to ask the last question of Amanda, because you, in a way, occupy this space beautifully for us today. You speak about your own experience as a daughter, and you also speak as a nurse. So I'm just wondering, has what you've experienced changed how you talk to your own patients now about the end of their lives?
Since discussing and talking with staff on the unit about the importance of these conversations, we've had a really positive response on the unit. Staff have said that they feel more comfortable in speaking with patients, for example, explaining why CPR is not always appropriate for everyone and the distress that it can cause for the family members. I've also had great responses with patients. One patient was really worried about having a do not resuscitate form put in place, and his wife thought him and his wife both thought it would stop all treatment and he would be left without proper support and care at the end of his life. But after lengthy conversations and reassurance explaining that this is not the case and he will be treated for all reversible conditions, and helping him to understand that with his comorbidities, the chance of survival and returning to a normal life is not going to be achieved with CPR. He then understood this and accepted the DNR order. He also went home following that conversation and spoke with his family about bringing his daughter's wedding forward, because it was very important to him that he walks her down the aisle. I'm also aware that I had a colleague that had a personal experience with her granddad following our discussions on the unit. She felt really empowered to speak up at the right time for her granddad, and he was then made comfortable at the end of his life, where a doctor was trying to bring him into hospital, and she stood and said, no, this is not how it should be, and that's not what he would want. And I know that all these changes are not on a national level, but it's having a big impact on the patients and the support of our staff and families at this minute on the unit.
Thank you so much, Amanda. Thank you for what you do on the back of your own experience. That's a difficult and worthwhile endeavor. I'm sorry we haven't had a chance to talk about more questions. The Compassion in Dying team are going to post a link to a questionnaire in the chat now, and they're also going to email that to you on the email addresses you'd registered for this webinar with. And we're going to ask you a couple of questions to tell us your thoughts, because this is obviously not the end of the conversation. Later this month, we're convening a roundtable of the people we believe need to be involved in designing this campaign we're talking about. And we want them to have your take on the back of the conversation you've just heard on what you think they should prioritize. So please do take the time to fill in this very short survey. It's just 3 questions. as I said, you can get help from info@compassionindying.org.uk if you so wish. We will not stop this conversation. In fact, we're only just getting started on it. And I'm very convinced that all the people on the panel and all the people who joined us today have a role to play in it all. So thank you for joining us today. And as I said before we started, if this has made you feel a little bit raw because you're dealing with things that are very close to your heart, take a moment and then continue with your day. I will do so, and I look forward to hearing from you all again. Thank you. Bye-bye.